Dear participants, welcome to the first embryology panel of the TSRM 2022 Congress. In this panel, we will discuss laboratory performance indicators with our valuable panelists. Our question to them will be, which performance indicators are the most relevant in your lab? First of all, I would like to briefly introduce our valuable panelists, whom you all know. Thomas Ebner from Austria, Borut Kovacic from Slovenia, and Dennt Sakkas from United States. Unfortunately, Rita Vasena from Spain won't be able to attend. Yes, I want to start with Thomas because Thomas is one of the valuable contributors to the Vienna Consensus, which published the ART Laboratory Performance Indicators reports, which we all use as a source in our laboratories and which we read often. What I want from Thomas, in short, is the methodology for creating these reports, definitions such as competency and benchmark, different groups of indicators such as reference indicators, performance indicators, and key performance indicators, and KPI types, structural KPIs, process KPIs, and outcome KPIs. I will ask him to give us this information because we have young embryologists in the hall. Afterwards, I will ask our panel questions to all panelists in turn, and they will tell us which performance indicators they consider first in their laboratories. And they will answer how to use these performance indicators, and also what do you think about the data collection frequency and minimum number of cases for the indicators, and how should we use performance indicators in very busy laboratories or laboratories with low number of cases. In the first round, we will give each of our panelists an average of 5 minutes. You can increase or decrease this time by a few minutes depending on your request. Then we will move on to the second round. What we will discuss in the second round, as we all know that the indicator values presented in Vienna Consensus reports were derived relative to cycles that met the criteria for a reference population. These criteria were female patients below 40 years old, own fresh oocytes, ejaculated spermatozoa, fresh or frozen, and no PGT cycles. In the second round, what should our approach be in groups that fall outside of these criteria? For example, in women with different age groups, in difficult cases such as poor ovarian response, in cases where frozen oocytes are used, and in cases where testicular sperm are used, and lastly, in PGT cycles. Again, each of our panelists will talk about these questions for an average of 5 minutes. Yes, we can start with you, Thomas.
So thanks. A technical guru next to me. Okay, sorry for that. So welcome everyone. Yes, indeed, I had the pleasure, like Bajak had, to be part of this group. And after the end, we came out with this Vienna Consensus, but believe me, at the very beginning, it was quite complicated to get a common opinion on very easy parameters sometimes. So it was like a discussion ongoing. One said this is too high, the other one said this benchmark is too low. So it's not a perfect paper, I should say, and maybe sometime it will need a revision. That's my opinion. But what we were really clear on was that all those indicators, they should be, or they are, objective measures to evaluate something like a healthcare domain in general, and in more particular, the progress or the performance of the lab that we work in. You have to use those indicators, sorry, you have to use those indicators, you have to monitor them, you have to evaluate them, and then you can actually see a curve over the year, whether you do a good job or not. And this allows you also to compare your performance with the performance of the competitors, with guidelines, with national law. It depends on the country. So it's definitely something that is needed and should be part of every quality management system, not only due to the fact that we now have the European tissue directives, which I think are not valid in your country. Yeah, not yet, maybe, because there are some good things as well, but definitely you have to evaluate and monitor your performance. And the next problem that we had was to distinguish between the different types. So what is an important indicator? And this is what is called key performance indicator, or KPI. So there was half a day we discussed whether 3PN after IVF is a key performance indicator or only a performance indicator, meaning that a performance indicator is less important but could, on top or additionally, also be evaluated. And I think good labs will use all those KPIs and performance indicators. And there was a third group of indicators, which was the reference indicator. Reference indicator here refers to the phenomenon that actually you can't influence those parameters. This is something that comes from the clinicians. I think that one was the rate of M2 eggs per collected cumulus oocyte complex. So obviously, if you only have 50% mature eggs after denudation, then there's a problem with the stimulation. So maybe, Borut, you will know, in the Maribor consensus, I think they came up with, 80%, around 80% of the eggs should be mature. This is a reference indicator because you, as a lab person, as an embryologist, you have no influence on that. And also the ratio between the follicles you see in ultrasound and the number of cumulus oocytes complexes that you actually harvest. So these, I think, are the two reference indicators that we had. So this is nothing that I would do in a daily work or in a monthly work in the lab, but I'll keep an eye on that. And maybe once a year or once in a half a year, I calculate how many eggs are mature. And if there is a problem, of course, I go back to those colleagues, the younger clinicians that did the stimulation, because maybe there is a learning curve with one or the other regimen. Yeah, and the last point I think I should mention is that we didn't want to come up with one single value, but rather with a range that you should be in with your performance. And the range obviously has a minimum competence value. This is the threshold that actually tells you that, if you are above it, of course, tells you that you do a proper job in the lab. So if the clinician comes and asks you, why have you only 70% fertilization after ICSI, then you can take the Vienna consensus and let them know 65% is the lower threshold, is the competency value. So your work, or you proved your competency with 70%, and it can be blamed on the patient cohort, for example. And the other thing, the upper level, was the benchmark value, which is the aspirational goal you should strive for, meaning that it's always, you should try to be top of the pop, as we say in Germany and Austria, meaning doing your best to steadily improve your KPIs. And to do so, or to fall within this range, it's of importance, and this is maybe my last point, that you use those KPIs in a reference population, the one you pointed out nicely just before. So it makes no sense if you use 50% of your TC patients and try to have 85% fertilization, which is maybe possible in obstructive azoospermia, but rather not in non-obstructive azoospermia. Yeah, this is more or less what we had in mind by doing this consensus before we started all the discussion.
Thank you, Thomas. Then we can ask our panel questions to all of you in turn. Which performance indicators you consider first in your laboratories? We can start with you again.
Again, sorry for that, guys. Well, personally, I would say, to my opinion, it should be a KPI after embryonic genome activation, because fertilization, if we're not speaking on complete fertilization failure, you can almost fertilize with all kind of sperms, almost all kind of oocytes. So fertilization is maybe not the best marker, but I would consider, for me at least, blastocyst formation to be the most important KPI. And I also think that the percentage of good quality blastocysts, which in the paper is only a performance indicator, should be a key performance indicator. So if you have 30 to 40% good quality blastocysts, so this is better than BB according to the Gardner score, then I would be happy. Yeah. And this is my favorite KPI, because this proves that actually you do a proper job in terms of pre-implementation development. Not saying that they are euploid or aneuploid, so this is something that we're not allowed to analyze in our country. But blastocyst formation tells you that your culture system is working.
How about day 5 embryo transfer rate?
You mean the pregnancy or implantation? Yeah, I think the implantation rate is mentioned. It's at 35% or something like that, the lower level, I think. To be honest, in times that we have so many freeze-all cycles, it's almost impossible to do, you use a 3-month data set based on the number of cycles that I have, and it's not sufficient because we have 25% of freeze-all cycles. So to show the lab performance, I prefer the blastocyst formation and the good quality blastocyst formation.
So what do you think about the data collection frequency and minimum number of cases for these indicators?
Now I didn't listen to you. I thought he's next. You have to repeat it, please, once more.
Okay. What do you think about the data collection frequency? Data collection frequency. Well, and minimum number of cases for these indicators.
I think we came up with a number in the paper, but personally, I think it makes no sense to do it in less than 50 cycles or so, which in some labs doing some 500 cycles like mine means this is more or less 6-7 weeks, every 2 months I do it. I don't do it on a monthly basis. Keeping in mind that if there is a problem or I do see some development that I don't like, then I also have to split this data to my colleagues and myself to see who is the problem or not, or who is the best. So this is something that gives you still lower sample numbers for analysis. So I would say it's at least 50 cycles.
50, okay.
It should never be, that from the time point here, it's 3 months, not longer, I would say, even if it's, if you have less cases in this period.
Yeah, the other question is, how should we use these performance indicators in very busy laboratories or laboratories with low number of cases?
Yeah, well, if you have a busy lab with 1,500 cycles or so, then definitely you need one person. Actually, the lab director is doing the analysis, the evaluation, and will have no time to do anything else because he or she is constantly analyzing the data. The problem is if you transfer or you have a problem in the system, it takes up to 2 weeks before you do the pregnancy test, and it takes up another week or so to see that you don't have a pregnancy in 10 cases or even more, and then you get the alarm. And this is why, or with a high cycle number, you have to do it more frequently, which means that the lab director has to dedicate a certain percentage of time of his duty only for analyzing those data. And the more KPIs you monitor and you analyze, the more difficult it'll be.
Understand. Okay. We can go with you, Borut. I will ask the same questions. Which performance indicators you consider first in your laboratories?
So thank you. I would like to comment first a little bit what Thomas explained. This paper is really helpful paper. It is old one now. It could be revised, but it was the first paper where we got instructions what to do with all this data that we usually collect. And we are very familiar with collecting all kinds of data. So it is very important that the database that we have is well organized, that we know what we put in the database, and that we have complete follow-up. This is maybe more important for clinicians for collecting data after 14 days after the transfer or 10 months later after the transfer to see what is the main outcome. But this is something that we have been done from the early beginning of IVF. So for laboratory part, we have all data all the time available regarding fertilization, regarding the quality of embryo development, blastocyst development rate, survival rate, and so on. But it's again important that we understand what we analyze. So this is very important when we get some outcome from calculation about KPIs, and we cannot understand why the KPI is now lower than we expected. So we have to work everything in close collaboration with clinicians, because they can change something in the protocol which can much influence the laboratory KPI. And what Thomas mentioned, for example, the reference indicator like oocyte maturity rate is very important. My experience is particularly with this reference indicator that we didn't know that something changed from the clinical part, for example. We had the oocyte pickups without anesthesia from the early beginning of IVF, and then we got our own anesthesiologist. So they changed the policy in the operating theater, and some gynecologists started to puncture also very small follicles. So the ratio of mature oocytes dropped a lot, and this influenced also the fertilization rate after IVF, particularly. Maybe not so much in ICSI, but also in ICSI, because in fact, when we do ICSI, we have chromosomally mature oocytes, but cytoplasmically not mature. So first look the reference indicator, if they are stable, or if there is something that's changed from clinical part. And then you can do the analysis. I think that the first indicator should be, for example, from laboratory part, fertilization rate. This, I think, is very quick information if all people work according to instructions, if they're well trained and so on. Especially if you have young colleagues in the team who started with ICSI procedure, you must have good control over the KPIs. This, at least, I think, the fertilization rate, or maybe also the generation rate, but not after ICSI. After denudation, because
right.
I saw that this could be the biggest problem from the beginning, when they start to manipulate with oocytes on the microscope and they're not well trained, they're losing oocytes during denudation. And sometimes I also saw the case from one embryologist, was not very sure, then she marked that the oocytes were not mature. But she was losing oocytes. And we recognized immediately, because we compared the maturation rate, and it was very strange that she had much higher number of immature oocytes than the rest of embryologists. Then we saw that they're not immature, they're lost during denudation. So these are some very, very details that can count a lot.
For the conventional IVF, the sperm preparation methods also affect the fertilization rate.
Yeah, for especially, we cannot do a lot in conventional IVF because we just put a drop of semen, and it's more or less everything up to gametes to do the things. But this can show you that what is the quality of all sites and gametes. So if it is expected to have 60%, I think it's the threshold for IVF, more than 60%, the competency level. But if you have 50% only, then there is something with the quality of, maybe the quality of all sites, or not the good selection of patients for ICSI and IVF. So.
Right. We can go with the other questions with you again, Borut. How to use these performance indicators, and what do you think about the data collection frequency and minimum number of cases for these indicators?
The number?
Minimum number of cases.
Minimum number.
For data collection.
Yeah, we tried to follow what is written in the paper. So I think it was 30 cases
30.
in clinical paper. It is 50 cases or per each month, what comes earlier. Yeah, if you want to calculate the performance indicators per individual, for example, and if you go to the standards that 200 cycles should be performed per each embryologist, for example, we are following this standard. So in our center, we have 1,200 cycles, 6 embryologists. This means 200 cycles per each embryologist, and 50% of cycles are IVF. So it's 100 ICSI cycles per each embryologist per year. If you take 30 cases, this means that 3 times per year you can calculate the performance for each individual, which seems quite long period. You cannot correct something if you see that something goes wrong. But this is if you follow the instructions, 30 cases per embryologist, for example.
I understand. So,
but if we have the young colleague, when they start to do ICSI, we prepared an Excel table, and they put all data from each case in this table. So the performance of fertilization, for example, is calculated for each new case. And when they have 50 cases, the first 50 cases, then we have the information about the performance.
okay, thank you so much. We can move on with you, Denny. First question is, which performance indicator you consider first in your laboratory?
So for the laboratory, I think if you're just looking at the laboratory, where probably the most important, I agree with Thomas and Borut, is that blastocyst rate, I think, tells you more about your laboratory. We actually look at what we call blastocyst utilization rate as an important parameter. So this is how many you freeze, and also include if you've transferred blastocysts also. So that tells us what quality blastocysts we're also generating. We're lucky because we're a very big laboratory. We do over 9,000 cycles a year, so the number of data we have is very easy, but we have many clinics that are much smaller, that do hundreds of cycles a year. So this is more of a challenge, as you said before, and what we tend to do in a lot of clinics, and even for down to per embryologist, is we use what is called a rolling average. So we actually look at 30 cycles continually, just continually going forward, and we look at if they're deviating from their average. So if they have a 50% ICSI rate, if that's going up or if it's going down. So it's a quicker way of responding at using a key performance indicator. So we can do that at the clinic level, and we do that obviously for per embryologist also. So the most important one we use is blastocyst rate, but I think as we all know, that you will know after 5 or 6 days, or maybe if you do it once a month. So, one of the first things we obviously look at is also fertilization rate. That tells you something quicker if you want. And then you have also your live birth rate or your biochemical rate, which tell you different things. So each key performance indicator will give you a different perspective of the clinic, of your laboratory, of the person. So these are all types of data that you should be collecting. And I think all the laboratory directors or embryologists here should put time into having a database. It's actually very important to have. You may think, oh, it's, you know, I'm busy doing everything else, but it's actually very important to have these databases because they do give you a lot of information, and it's better to understand if you have a problem today rather than, you know, in 9 months' time.
Performance, what is the percentage of conventional IVF in your lab?
So we do about 50% conventional insemination and about 50% ICSI, so probably about 50-50. We're a different US laboratory than a lot of others though, because we have Massachusetts, so in Boston we have health coverage for IVF, so we're a bit more like the European. We do IVF like Americans do, but we have coverage like Europe, let's say, because for a lot of our patients there is coverage by health insurance for IVF treatment.
Mm-hmm. I see. Okay. Thank you, Danny.
I'm sorry. I need to interrupt. I'm so sorry. Can you please speak closer to the microphones, please? Because it's really hard to hear you from the, salon.
Okay. Thank you, İpek. As we all know that the indicator values presented in Vienna consensus reports were derived relative to cycles that met the criteria for a reference population. These criteria were female patients younger than 40 years old and on fresh oocytes, ejaculated spermatozoa, fresh or frozen, and no PGT cycles. In the second round, what should our approach be in these groups that fall outside of these reference population, these criteria? For example, in women of different age groups, in difficult cases such as poor ovarian response, in cases where frozen oocytes are used, in cases where testicular sperm are used, and in PGT cycles. You can start first.
You see, I had a learning curve. It worked. I switched on the microphone, and I'm closer to the microphone. The only problem is I have no message for you, particularly for the frozen oocytes, the vitrified oocytes, because we do not have very much experience with that, because we're not allowed to do social freezing, so all we do is do it in fertility protection cases. And we do see, of course, I have to say, that we have a lower fertilization rate, a little bit a lower fertilization rate, but this depends rather on the survival rate after warming and not on the ICSI process per se. So if I would only take those eggs that survived the warming morphologically and hopefully also within the cell, then it should be at least maybe 5% less than the threshold that we mentioned. This was something that we did for the cryo consensus with alpha, saying that it's 10% less than fresh was, I think, what we calculated. So maybe this one can also be used here. Those of us who do, you know, more cases of oocyte vitrification and ICSI with warmed oocytes, they will maybe have the same results that we can discuss later on. For TC material, I would say, if it's non-obstructive, if it's only an obstructive case, I think fertilization rates are almost as they are with fresh semen. Should not forget, if there's only one case with a lower fertilization rate, it doesn't have a great influence. So if you take 1 month or 2 months and then you evaluate the data, on average, you will then have a fertilization rate is maybe 4% less than with regular ICSI, or 5%, let's say. But overall, you're still within this range that I mentioned before. This means that you don't even realize that you have a little bit lower fertilization with TSRM material. So what I do in those cases, I analyze separately. They're not part of the general analysis, but I use them separately to analyze it. Or if there is a drop, if there is a drop in any rate, and I do the overall calculation, and then I go deeper into the matter, and then I take these groups out. Because to be honest, from the very beginning, I use almost all cases to do our KPI analysis, irrespective of age, irrespective of the sperm source, because I don't have that many cases. So it's 500 to 600 a year. And as Borut said, we are 5 doing the whole thing in the lab. This means I need any case to get a sufficient sample number. But then if I see a problem, then of course I go into detail to see if it's related to the colleague doing the job or if it's related to the sperm source. And luckily we only had one issue, and this had something to do with, actually we think it had something to do with the immobilization process during ICSI with the trainee. So this is one very important aspect that Borut mentioned. It should be clear that you only analyze the cases of the experienced, of those that are allowed by the quality management system, allowed to work, to do an ICSI case alone. Because at the beginning, most probably you split the eggs. So 1/3 of the eggs goes to the trainee, and 2/3 are done by the more experienced embryologist. So please only analyze those data, except the trainee is doing better work than the experienced embryologists. But this is something that you'll find very easy.
What about cases such as poor ovarian response?
You mean with less than 3 eggs?
Yeah.
Yeah. Less than 3 mature eggs. For me, it makes no difference. The prognosis is worse, most probably, in terms of aneuploidy, that what Danilo said this morning. Also on pregnancy rate or live birth rate, most probably. But this is not a KPI that I use at the very beginning to analyze the lab performance. So for me, it makes no difference. The number of oocytes makes no difference. But then once it comes to pregnancy rates, then it will make a difference, of course.
How about PGT cycles and different age groups?
No PGT in Austria. Or we just started, so I better make no comment.
Okay. Okay. We can move on with you, Borut.
Before, I forgot to say that the first KPI is fertilization rate that we calculate, but I think that good blastocyst development is the best indicator to show the laboratory performance. That's true. If you not to do too rigorous selection between patients for blastocyst culture or not. So regarding the reference group, we selected the best group. These are younger patients, first and second attempt, with more than with 5 or more oocytes for ICSI. This is something, and also regarding the male factor, I'm talking for ICSI now, fertilization rate. The sperm source is separated, so surgically retrieved sperm and cryptozoospermia is one group, and the rest of ICSI is another group. So I think this is important also when you look the performance per individuals, because particularly with these very difficult cases, it depends how persistent are embryologists. Someone can sit with the sample 10 minutes, another one can sit 4 hours looking the sperm, and this is very important. The problem is only that you don't have so many cases that you can get immediate information about the performance. But after 1 year, when we have 60, 70 such cases, you can get a feeling about the performance per individuals. This is the best patient group is used as a reference group because I think we can compare then the KPIs between different periods. I also believe that this can be compared with any other IVF centers. But we have to mention that these problematic groups like poor responders, this is the weakest link in the chain, and this is the most sensitive part. So if something goes wrong, then especially these cases will be the first who will show that something is not optimal. So don't forget that maybe it's we should look these difficult cases, where we have only 1 or 2 oocytes for ICSI, how they finish them. Regarding PGT, we don't do PGT. So
How about frozen oocytes?
poor prognosis, yeah.
Frozen oocytes.
Frozen, yeah. For frozen, we just look the survival rate. We have only blastocyst vitrified. Yeah, survival rate is morphological survival rate, which is characterized by the sign of expansion. And at least 50% of embryology mass should be viable or intact. This is our sign for that. And then we are following what is survival rate, optimal survival rate and survival rate. So optimal means that blastocysts completely re-expand in a 2-hour period of time. And it's not just a compact group of cells within zona. So this is our criteria for survival.
Thank you. Thank you. Danny?
So we do PGT. We do about 35% of our cases. We do PGT. And in relation to the laboratory, the key performance indicator we watch most carefully is actually no results. So when a biopsy is performed and we actually have no result back from the genetic testing laboratory. In general, we expect about between 1 to 2% of blastocysts that are biopsied to come back with no result, but we will see embryologists with 5% or with 0% also. So this is the main indicator we use. We don't look at euploidy rates, although we do track them, but it's more of a, I think like Thomas said before, there's a difference between a performance indicator and a key performance indicator. So for us, for biopsy, probably the most important is actually getting the analysis back, and we do see differences between embryologists. For egg freezing, so we perform a lot of egg freezing. Obviously there's egg freezing for fertility preservation, and there you just don't know. You don't have any outcome, but the majority of egg warming we do is through donor egg banks. So we work with a lot of different egg banks. We expect well over 90% survival rate, and we expect actually a high percentage, over 50% of those to be usable blastocysts, so freezing blastocysts. So again, that's our golden criteria for egg freezing, because the majority of patients we're doing egg freezing, or the majority of egg freezing patients we work with a donor, so very good quality. So we expect a very high rate of both warming and blastocyst, and obviously pregnancy rates too.
Mm-hmm. So how about different age groups? So
as mentioned before, we have our gold standard of patients, if you want, so under 35 with 5 or more eggs. So that's sort of the age group that we use as the gold standard. But then every age group has their own rate. So you can't use one age group as a you know, I'm trying to get up to 50% blastocyst rate because that's very different from a 35-year-old versus a 40-year-old or older. So, you know, it's very important to establish your key performance indicators, again, you know, per age when you can. And you know, we use mostly under 35, 35 to 38, 38 to 40 and greater than 40. You know, that's you can always have a gold standard, but you need a standard within each age group, which is very important because each age will respond differently to, you know, to any parameter, whether it's probably less so fertilization rates, but blastocyst rates, for example, will differ. Obviously, pregnancy rates will differ between those. So each of our age groups are treated separately, and I think that's probably, I think, when doing key performance indicators, the biggest challenge is numbers. I think you know, we've all mentioned, you know, what number do you use, but that, I think, for every laboratory here it's very different. For a big laboratory it's much easier because you have a lot of numbers, but then if you're doing a clinic that, you know, does 100 cycles a year or 200, 300, even 1,000, it's hard to get those numbers and then to start looking at the finer points, you know, age groups, testicular biopsies, you know, because you're doing less of them. So that's where something like the consensus report gives you at least a parameter that you should aim for. But also, you know, there's a lot of literature out there too that, you know, will tell you, you know, this is the fertilization rate that I should be having. So I think for a lot of groups, you should also be looking at, you know, the consensus report as a reference, even though it may not be from your own laboratory, but also, you know, from the literature also.
Okay. Maybe we can have some questions from the audience. Is there any questions from the audience? Salondan soru alabiliriz arkadaşlar. Sorularımızı tamamladık panelistlerimize.
Can I just mention too that I think we all sort of talk about key performance indicators. Sometimes we're talking about negative, so we're looking for the bad thing. But it's one thing you have to remember, that you can find the good things too. So many times we will find an embryologist who is getting ICSI rates 5% above everybody else. And what we then do is we actually get all the embryologists to watch that particular person doing ICSI. How are they, you know, because if you have a lot of people in the lab, sometimes there is protocol drift of what we call, and we think of key performance indicators to tell us when there is a problem in the laboratory. You know, the media is something wrong, the oil, whatever. But they also they're very helpful too. So you know, sometimes we will have an indicator that we see someone that's doing biopsy better than others, or ICSI better than others, or has a higher blastocyst rate or transfer rate. So you can also use your key performance indicators to improve your training skills too, and that happens quite frequently in our laboratories too.
Thank you. Sorusu olan var mı acaba? Başak.
Does the microphone work? Yeah, okay. So maybe, Danny, you were at ASRM. There was an abstract on the North American clinics, data from, I think, 60,000 cycles. I don't remember exactly. Do you know about this abstract, which was orally presented at ASRM? And there it was very clearly shown that Vienna consensus can sometimes be unrealistic in terms of benchmarks, especially. Would you comment on that?
Yes.
In routine practice, it may not work like that.
There were some parameters, I think, that were criticised that they were actually too high a bar, I think. I've been on these consensus meetings, so I can imagine the discussions that went on between everybody. It's important to have those barriers, you know, that consensus, but you know, it's just as important to have your own aims too, I think. And you're exactly right. One of the criticisms, I think, from that presentation were that, I don't know, 50% of the laboratories in the US fell under the ICSI rate. I can't remember the exact data. So there was it was an interesting discussion showing the variability between laboratories, but also that some of the parameters that people sort of strive for were probably less than what maybe the consensus report, aimed for.
Can I comment? Yeah, I know we were talking in ESHRE certification board when we are comparing the clinical outcome with different centers, and we also faced with the implantation rate, like the competency value that is a little bit too high in the consensus paper. And this is something that what I said, it is very important to follow what is the clinical background. But regarding implantation rate, this is performance indicator that is partly laboratory, partly clinical indicator. We tried to do the comparison between the implantation rate per different staff members, clinicians, and also embryologists, and we found the difference in both groups. When we analyzed the details, we observed, as Danny said, we should look this as a positive, in a positive way. We found that we used very different volume of media in the catheter, and then we harmonized the procedure after that. So it should be a consequence when you see, not negative consequence, but in the sense of improving the system.
May I also add something? Because I think that with all those performance and key performance indicators that we put in tables, actually we missed one very important one, which was the 3PN after ICSI. This one is not even mentioned at all. 3PN after IVF was mentioned. So I have no idea if we simply forgot it or if someone said this is not of importance. The other thing is that there is one indicator in it, I think it's a performance or it's a key performance indicator, which is completely useless. At least it has nothing to do with the aim of this consensus, and this is the number of motile sperms after preparation for IUI or IVF. I have no idea how, well, I know exactly how it worked. I think it was David Mortimer trying to convince us to put this very important KPI in, or PI. But to be honest, for ICSI, you need only one motile sperm. We of course try to only use motile sperms. So this is a little bit off the path, I would say.
Right, I agree with you.
And one more thing, the degeneration rate, 5 to 10%. So 10% ICSI is a degeneration, 10% of oocytes after ICSI, I think is very high. So if my colleagues would damage 10% of oocytes, definitely they will not do ICSI any longer without the proper training. Having in mind that the tools, the micro tools, get sharper, every other day more or less. So this is something that is not perfect, but at least it was a first good attempt, and maybe definitely we should redo it and add more parameters.
Yeah, I agree with you. I want to say our overall performance of the laboratory are closely related to clinical part. So we should closely communicate with clinical part as embryologists. This communication is very, very important. Any change in the clinical staff, ultrasonographic evaluation, all of these small changes will affect our laboratory performance. Başka sorusu olan var mı acaba salondan? Konuşmacılarımıza teşekkür edip kapatabiliriz. Thank you for your valuable comment and discussion. Okay.
So just one comment, I think, going from what Başak asked before about ASRM, but there was a lot of discussion about using artificial intelligence to track key performance indicators. So, you know, we've classically been told that they'll improve our pregnancy rates by picking the best embryo, but there was quite a bit of discussion about the use of artificial intelligence to track these in the background and be able to sort of tell you when you have differences. So I think maybe in the future we'll be, you know, using some sort of other automatic modelling, if you want, to warn us about, you know, if things are drifting within the laboratory or within the clinic, as you said before.
Thank you. Thank you all for your valuable comment and discussion. Evet, kapatabiliriz arkadaşlar. Teşekkür ederiz.